Mentor friends. I am glad to see some of you guys logged in, but I am glad that anyone that gets to watch this is going to learn so much because our guest speaker is the wonderful, amazing, brilliant Elaine Siegfried, Dr. Elaine Siegfried. She's a professor of pediatrics and dermatology at St. Louis University. And that is where I train. So Dr. Siegfried is not only amazing and wonderful and all of those things, she's also a dear friend because she has been my mentor since, gosh, I don't know, at least 25 years now.
Mid-90s, I think, yeah.
Yeah, mid-90s, exactly. And we were just talking, you want to show them the picture behind you, Elaine? That picture was in her office the very first day that I met her. And I still remember it as a young medical student. Elaine was the very first pediatric dermatologist that I ever interacted with. So I am just, so honored and thrilled and glad that you are here chatting with us tonight about the logic of biologics.
And the two of us are here to at least, we can't not mention that there's a huge shortage of all pediatricians and pediatric specialists. It's this year they had an actual decrease in applicants for pediatric residencies, although the number of medical students who were matching this year was higher than it's ever been. And increasingly, I think people are uncomfortable taking care of kids. So we're hoping to give you some pearls about taking care of kids with biologics. But we also are hoping if we have any trainees or learners here today to inspire you to go into pediatric dermatology. It's the best pediatric and dermatology subspecialty. And so, it's, if I think for most people, they are somewhat intimidated maybe by parents and children. It's not bad. They are more intimidated maybe by the salary, but it's not everything is about the money.
Nope, it sure is not. It's not what you become because of it, not what you get because of it.
Yeah. And then think about coming to the Society for Pediatric Dermatology meeting. Alana and I just were at that from this year, and I'd say it was probably the best meeting I ever attended. And, back in the 20 years ago that we had between 100 and 200 attendees, and this year we had over 700, and the quality of the education was phenomenal.
Yeah, well, I mean, when I met with you as a medical student, pediatric dermatology wasn't even board certifiable, which is crazy to me. And it's just been a welcoming, it just has that family feel. And I think it's number one, because it is small, but even as it's grown, it's kept that because I think it really is a very special personality that wants to go into this field, and it really makes it feel like family. And your colleagues are there, they have your back, and it is pretty special. And I knew that right away from the very first meeting that I went to when you introduced me around and people that I had seen names on textbooks and then, all this, and I'm just meeting them like they're normal people and they're at the pool and they're at the beach and they're going out on boats with you on the optional activities. So, I mean, it's a pretty special group of people. And I think anybody that would choose to go into it would be just very lucky. And I know I feel that way. And I know you feel that way. And there's 9 states in the country.
You could do a whole webcast. I'd be happy to help you on the advantages of being a pediatric dermatologist and just getting to know the subspecialty.
I love it. Let's do it. Let's do it, because everybody tuned in to hear the logic of biologics. So let's get into that. But yes, I love the idea, and we are going to do another podcast. So everybody stay tuned. All right, but let's kick us off. So, when I first started pediatric dermatology, I remember when I was in residency, Protopic, topical tacrolimus, came out, and it was the first new medicine that had come out in dermatology in so long. And that was a big deal. And fast forward 20 years, And we have just an explosion of medications, which is really exciting. And one of the words you taught me was therapeutic orphan. It's one of Dr. Siegfried's words.
No,
And
well, I didn't coin that for sure. That was Dr. Kemp. Yeah.
okay, well, that's who it started with. But yes, you had taught me that. You had passed that to me. And it's so true. Even today, while we're so lucky to have so many treatments, it's still lacking in a lot of ways. But it's exciting because they're all starting to come out and it's things that we prayed for years. So again, tell me about the biologics in children. How have you seen it evolve over your career?
I never thought in a million years that we would have such effective treatment to treat kids with inflammatory skin diseases. And of course, eczema is a much bigger problem, or has been, is so more common than psoriasis. But for both of those indications, having options it's really been amazing to me. And it took patients from being well, I use the term nomophobia. So, when everybody has their schedule and you look at all the names that are coming in because you want to do some pre-chart review, and then you see those names on the chart that are like, I don't know what I'm going to do with this person. They have such bad disease. That's what I call nomophobia. Nomophilia, on the other hand, is somebody that, you maybe you haven't seen in a long time. So and are probably doing well. So having biologics available, especially for kids with bad eczema, took the nomophobic patients and it made them into the nomophilic patients. And they're like, wow, I haven't seen that kid in a year. I wonder how they're doing. They must be doing great. And then you just get to catch up. It's really been amazing.
Yeah, yeah. And I remember, yeah, do you remember when you used to have the SAD club, the severe atopic dermatitis club? That was something that you talked about a lot.
Oh, that was terrible. Yeah, but we don't have that anymore,
The
and for
SAD
people
club
that
has been disbanded, and it's
it is
amazing.
it is amazing.
It's
It's amazing.
amazing. So, who do you think is a good candidate? Like, who do you think, you consider starting on biologics?
I always kind of think about it as beyond topical therapy, so we always start with topical therapy. And, topical corticosteroids in labels and, publications, people talk about, oh, when they failed topical steroids. You don't really fail that treatment because that treatment does work. You just can't keep it up. And of the subset of people that fail it, there's a whole bunch of other reasons. And one of them is it's too hard. Like for years, I monitored quantities. I still do of the topical medications that people are using. And if they're not using enough, the answer is that you got to use more. But there's some people who are just not capable of using more. And frankly, there are some payers that won't pay for enough. So when you talk about the calcineurin inhibitors, they're limited to 100 grams a month. We were in the clinical trials, we were using 100 grams a week, for some of these patients. So either you can't get enough or you just can't use it. It's the tyranny of topical therapy. It's just time consuming and difficult, and it burns and stings, and those kids when you see them. But I do use lab evaluation as well to try to identify patients, and especially to try to identify which biologic are the best ones for them, because now that we have a lot of choices, you got to know which ones to go for. So the screening evaluation that I typically do, I like to do an allergen panel. And the one I use now is respiratory allergen panel. I used to use the one that was called the March panel, for kids who were specifically had atopic dermatitis. I don't use that one anymore because it has food in it. And as we know, if you have elevated IgE levels, it doesn't mean you're allergic. It means you're sensitized, but it creates a lot of confusion among people and families, based on those results. will want to, put kids on a restricted diet, which we know is not a good thing anymore. So I do a respiratory allergen panel, and I do a CBC and a CMP just as baseline screens. I frequently check a vitamin D level in kids too, because frankly, lots of kids with inflammatory skin disease have low vitamin D, and supplementing that may help their skin disease. Hard to know, but it's cheap treatment and easy to do. And then it is a little more controversial, but if I'm thinking about putting a kid on a biologic, I will also check an ANA and a histone level because those are somewhat, sort of like poor man's markers of a tendency towards autoantibody formation. I'm a little concerned about the role of anti-drug antibodies in long-term efficacy. And this might not be a good thing to do, but we don't have commercially available anti-drug antibody levels except for just a very few of the biologics that are the little older ones. You can get used to ustekinumab.
Yeah, and do you find that elevated a lot, the ANA
I
and
do. I do.
antihistamine?
Now, I have not gone back and done a retrospective, review to see if it's sort of higher than in the general population. It's on my to-do list. But I am frequently surprised by how often those are elevated and sometimes significantly.
Yeah, and I guess that whole inflammatory milieu, right, makes them more prone to that too. And have
Yeah.
you correlated their response with those at all? Just anecdotally? I mean, I know you haven't done a study.
Yeah.
And like,
Yeah,
have you noticed that maybe if they're positive, that they might not respond as well, or not really yet?
maybe, but yeah, I haven't cranked
Story
out
yet
that
to be
information. Yeah, still
story
kind
yet to
of.
be told.
Yeah, yeah. In the days that we only had immunosuppressants, and also I would definitely consider this for any kid that you're thinking about putting on a JAK inhibitor. I do a screening immune surveillance because we know that there's a small subset, but an important subset of children who have immune deficiency dermatitis. It's sort of a mimicker of atopic dermatitis. And by the way, I think atopic dermatitis as a pure disease is way overdiagnosed. Like I see people who are diagnosing kids who have nummular dermatitis or what I call overlap, with a psoriasis um, tendency, or kids who might have nutritional deficiency or immune deficiency presenting with dermatitis. So if you're thinking about putting somebody on an immune suppressant drug, it behooves you to do a little screening evaluation for them, beginning with, do they have frequent otitis media? Have they ever had a pneumonia, sinusitis? And in children like that, and it's not uncommon to have children like that, I'll start doing I'll check their pneumococcal titer responses or H flu or diphtheria. That's because that's the most common thing that I've seen over the years that's abnormal. So that's called selective antibody deficiency. When you do that, you might have to re-immunize them, and then 6 weeks later you recheck to see if they boost. But this is kind of a specialty thing for kids that you're thinking need an immune suppressant as opposed to a targeted biologic therapy.
And is that something that you would refer if you didn't feel comfortable? Say some of our colleagues may not feel comfortable ordering those or interpreting those, or may not have a great relationship with an allergist. Would you just refer them to an allergist kind of with a
Yeah.
question as to, is there a potential immunodeficiency here?
So the reason I started learning how to do immune deficiency evaluations is because our immunologist wasn't particularly interested in this subset of patients. There are a very small number of immunologists that are, but mostly it's hard to find them. And it depends on, you have to have a good relationship with your allergist, immunologist, because in the old days, this happened to me quite frequently that, they would go to an allergist and they would get put on an elimination diet. Now, fortunately, our allergists at our institution aren't on that bandwagon anymore. And so we're much more on the same page. But I think for everybody out there in the community, you really have to have a relationship with your allergist.
Yeah, at least find one good one out there to kind of buddy up with for sure.
Yeah.
Yep, yep, because that is important. And again, like you said, it's surprising how often they do have an underlying immune deficiency when you start screening. And I do find those kids just don't really respond as well either. They're the subset that are more resistant to treatment, I think.
Absolutely. Yeah. And when the reason I even started doing it is I was putting them on cyclosporin and methotrexate. They were getting sick. Or you could start seeing herpes much more than you used to be able to. And in fact, when dupilumab was first FDA approved, the first kids that I put on that and the ones that I got in clinical trials when they were little babies were the kids who were that phenotype. They were covered with herpes and strep and, frequently ill and otitis media. And they did so well. So in a way, having these targeted biologic therapies it's kind of dumbing things down for us because you don't have to pay that much attention to those subsets anymore. But there still are subsets, and so we'll talk about that too.
Yeah, yeah. Well, as far as like directing therapy then, so you get your labs, and then how do you kind of think about agents and again these phenotypes? How do you kind of stratify these kids as far as which one they're going to maybe do the best with?
I think the most common subset is the truly atopic people, the kids who have, strong atopic diathesis. So, they got a family history of atopy, they may have had reactive airway disease, if they're littler, or been diagnosed with asthma and rhinitis, allergic rhinitis, conjunctivitis often, and then the ones that aren't growing well. And if those kids aren't you have to determine whether the kids who aren't growing well are atopic or not. And that's another blood test that I get. And when I get a CBC, I now pay a lot of attention to the eosinophil count. Didn't used to, but because we're discovering more about hypereosinophilic syndrome, which is again another phenotype. But the most common subset of hypereosinophilic syndrome in children is like having eosinophilic gut disease. And we know that dupilumab is effective for that, and others I think are going to be studied that way. So, I pay attention to their eosinophil count as well. And another little pearl, though, because I think that, so the definition of hypereosinophilia is an eosinophil level of greater than 1,500 absolute eosinophils 3 times sustained over 6 months.
Huh.
So not an easy thing to understand, but in paying attention to eosinophil counts over the years, what I have found is that, aside from the kids who aren't growing well, who may have eosinophilic esophagitis or gastrointestinal disease, and by the way, they don't all have eosinophilia, but the other big subset of kids who have quite dramatically high eosinophil levels are the kids who have allergic contact dermatitis. Again, an anecdotal observation, but it's, I've seen it. I probably should put together a retrospective review, but hard thing to prove as well, allergic contact dermatitis.
Yeah, and do you screen patients for allergic contact dermatitis before you screen
Absolutely.
biologics? And
Yeah. So
yeah.
so the atopic patients who have a high IgE level, so that's why I get that panel. And especially the ones that are pan positive, and the higher the total IgE, and especially in the setting of eosinophilia, the more likely I am to put them on dupilumab, because that's, been defined as a good drug for them. But I forgot what you just asked me.
As far as patch testing.
Oh, patch testing and allergic contact dermatitis. I mean,
Yeah.
the first thing that I do is I, look at their pattern and what their distribution of their dermatitis. I mean, certainly if they've got eyelid dermatitis, I'm like, you probably got allergic contact dermatitis. The only other thing that causes eyelid inflammation is herpes, and that cannot look like herpes either, but it tends to be unilateral, whereas contact dermatitis tends to be bilateral, sort of the way that I think about it. And, because patch testing is so challenging, and especially in young children, and it's just, hard to read, and the sensitivity is low, from the get-go, from the very first time I see patients, I very much emphasize, stay away from what I call complex topical products, or the cosmeceutical industrial complex. So I'm a purist. And by the way, did you see our SPD president, Dr. McGinnis, do a TikTok video about what topical emollients you should use in babies?
Which one did she put Aquaphor in there?
No, go Sheila. She actually had a jar of Aquaphor and had a jar of CeraVe, and she went, yeah. So, I just stick
She's
with
got a big reach.
plain petroleum jelly. But I haven't one more pearl about that, because especially for the immunocompromised patients who are covered with strep, and especially if they have furuncles, that furuncle phenotype, I think a lot of them are impacted by using jar medication or jar emollient and redipping and contaminating it. And I've done cultures of the jar and the kid, and they have the same MIC profile, so.
Yeah, it's amazing. I mean, I had a family, and that's all it was, a double dipper, and had $1 million workup for all this immune deficiency, had seen infectious disease. They had, I mean, treated the kid up and down with all kinds of oral and topical antibiotics. and nobody asked the kid if they were, double dipping in the tub. I'm like, that's just a big job. It's a big petri dish. It's a big petri dish.
You
And
know what? I didn't
kids,
understand. You don't
yeah,
need to put preservatives in petroleum jelly. And that, of course, is the
yeah.
advantage of Aquaphor and why they made it. It's got, the wool wax alcohols in there. But petroleum jelly doesn't have any preservatives. And I was still kind of confused about why it would get contaminated. But a colleague that I met from Unilever many years ago explained that to me. So it's really the cellular debris because there's water in those cells that, you're contaminating in there. And that's what grows the germs. But the petroleum jelly itself, they have like a 100-year-old jar of Vaseline at Unilever that they test it for contamination every few years, and it's,
Ah,
yeah.
that's really fun. That's really fun. But yeah, I mean, they're basically, yeah, wiping their hand on a kiddo that is just covered in all of that stuff and then putting it right in there. And of course,
Yeah. And don't
yeah,
get to the
so
folliculitis furuncle phenotype.
that's what they're doing.
Yeah.
Yep. And that's why we also should never just put triamcinolone in a jar. Not only does it get overused and they get HPA axis suppression because they're using a big old tub, but it also gets contaminated. So
Yeah.
many reasons not to prescribe the 1 pound tub of 0.1% triamcinolone ointment.
Right.
Yeah.
Sometimes in the spirit of being cost effective, I say, well, you can use it. You just have to cleanly dip, use a butter knife or something, or take like 30 grams, measure 30 grams of a topical corticosteroid, 2 tablespoons, put it in a separate jar, and that's their 1 month supply.
Yeah. That's another way to do it.
Yeah.
That's smart. That's smart. All right. So the allergic atopic diathesis kiddos that have other atopic issues, dupilumab, great option.
They're the
Great
first
option.
one. Yeah, that's the first
Probably,
one.
yeah, head and shoulders above the rest because
Yeah.
it not only treats the atopic, it treats everything else, and their quality of life just really improves so
Oh,
dramatically.
amazing. It's amazing. But
Yeah.
then that gets us to the Dupy failures, and so I
Yeah.
try to forestall Dupy failures again by being a good clinician and trying to pay attention to what I'm looking at. And so the kids who have like a psoriasis overlap, now some of them do okay on Dupy because I think if their eczema is kebnerizing their psoriasis and you can treat their eczema, then you won't get their psoriasis. But
That
there's
makes
some
sense.
people who have more of a psoriasis, diathesis. And so then you give them a type 2 skewing, a type 1 skewing anti-type 2 treatment, then their psoriasis is going to break out. And for a lot of those kids, they have facial or they, come back with those nummular lesions and they're not really good candidates. And of course, the allergic contact dermatitis kids are also really problematic. I mean, we just don't understand the immunology of allergic contact dermatitis. It's a big problem.
It's a big problem. I'll tell you. I know firsthand now. Yes, I do. It is systematized allergic contact dermatitis is the pits, and patch testing is not fun.
And yeah, it doesn't even tell you everything that you need to know. It can start.
Yeah.
Actually, today we had grand rounds and we were talking about allergic contact dermatitis, and our contact dermatitis expert said, it's good to do patch testing because then you can give somebody a cure. And I'm like, really? Not a cure.
Well, if you find, so again, I was allergic to cocamide DEA and I had it in the hand soap I was using throughout the house. And so it did substantially improve it once I fully got rid. So if you find a true contact allergen that you can find that is being used,
And
then
eliminate it. That's the key.
and eliminate it because not sometimes that's easier said than
Yeah,
done.
yeah,
But yeah, but it's rare. It's rare
yeah,
because they
yeah.
usually have an atopic diathesis underneath. So do you find that if you have an allergic contact dermatitis, the literature kind of shows that dupilumab should maybe work for those patients with allergic contact derm?
Well, the literature is really conflicting, so there's some reports of, it's just like with alopecia areata. There's
Yeah.
some reports of getting better and there's some reports of getting worse. And there's also reports of patch testing pre and after starting Dupixent where their patch test profile changes. So my interpretation of all that is that the immunology of allergic contact dermatitis is dependent on both the host response and the allergen type, because it's not that straightforward. We tried to do a big analysis, like just looking at all the reported allergens, just like Jenny Moraes did. And we didn't find, any specific allergens that did better or did worse consistently in the reports.
Okay. Okay. Now, how about, okay, moving on to another phenotype. So we talked about the atopic. How about your non-atopics? What do you think of those? Just their atopic derm, or those overlap kiddos, those
Yeah.
psoriasis.
Overlap, or even the allergic contact dermatitis kids. My go-to first line for them is still methotrexate. I think methotrexate's a great drug, not a biologic, but I think that it's every bit as tricky to use. And there's pros and cons to injectables too. I mean, you don't see needle phobia real commonly, but when it's there, it's really problematic. So
Yeah.
methotrexate's a good drug. And it's interesting because many children who are needle phobic, for using their auto injector or their pre-filled syringe at home, somehow tell me that getting blood draws, phlebotomy for lab tests doesn't bother them. It's weird.
Yeah, well, it's kind of like when you see somebody else's blood, it doesn't make you pass out, but if you see yours, you can pass out. Like, you know what I mean? You get
Yeah.
more vasovagal with it, right? Because it's you. Like, if you have to do the shot, it's going into you and
Yeah.
you're doing it anyway. So pre-filled, yeah, talking about Dupy and Dupixent, dupilumab, just so that everybody knows, those are all the same thing for our learners. So as far as the pre-filled syringe, and then doing the injector, the auto injector, what do
I
you
have
think
two
about the
good
difference?
stories about that. I mean, some prefer one, some prefer the other. It's weird. And I've done a poll. And by the way, I've got hundreds of kids on injectables now. But when I do a poll about which they like better, some like one and some like another. So you can't really predict that very well, even if you show it to them first. But and you would think that the auto injector would be something that would be a little more predictable. But I started a kid just this week on dupilumab, and they had the auto injector and auto injector training, and then they got their next dose, at home. And I was on a telemedicine visit with them, and I said, "Are you ready to do this injection?" And she said, "Okay." I said, "Okay, you just press it on their skin." And when I said that, this mom just pressed the yellow plunger down, and all of the medicine squirted out all over the place.
Yes, yes, that is a potential problem.
So yeah, like I just think people need more education about no matter what injectable technique than you think they do.
Yes, I think that's fair. I think that's fair, and holding their hand. And if you can involve a child life specialist, I mean, that's ideal if you have access to that. I mean, but certainly they're almost as rare as pediatric dermatologists.
Yeah.
And there are some things on the websites that can help but it's
Oh
it's
yeah, the
challenging.
other thing is so Regeneron has an ambassador program. So that's a program for parents who are on the fence or unsure, just want to talk to somebody. These are parents of children who have been treated with dupilumab, so they can help talk to them about any kind of concerns.
Yeah, I love that program. And it is because it's somebody that has been in the trenches with them, before, has done it. So they can rely on them because we can say what we want to say about it. But if you can speak to somebody that really gets it and had the
Yeah,
same lived experience, it's so much more powerful.
yeah.
So yeah,
But
great
so
program.
back to methotrexate and the Dupixent
Yes.
failures, like sometimes I'll actually add a little bit of methotrexate to the Dupixent failures, especially for kids who have contact dermatitis. And that can be sort of helpful, like maybe 5 milligrams a week. It makes them have to go back and get lab tests, but it's still not that frequent on such a low dose. You don't have to worry about it so much. And a low dose like that is really well tolerated. So for the overlap kids or the allergic contact dermatitis kids that you might have started on Dupixent and they're not doing well, adding a little bit of methotrexate is a good alternative.
Yeah, that's a great tip. That's a great little pearl. Yeah. And as far as Dupixent failures, what do you classify as a failure? Like they're just not getting better. They, what,
That
and
is a
again,
great question. And also, it's for us and it's also for the FDA. So in the
right.
clinical trials, it was something like 30% of kids at 16 weeks got clear or almost clear, which doesn't sound like an impressive number, but I can tell you that those kids feel way better and they're not about to change medicines because they're happy with that. But now we have emerging data, that's going on a year, long-term data, and we know that the efficacy, kind of gets better and better as time goes on. So that clear or almost clear is a goal. I do think that there's a difference between clear and almost clear in terms of maybe long-term remission, and that's a subject that's currently being actively investigated. But so that gets us to when do you get kids off of medicine? But they're happy, when they're even
Yes.
mild, because it's so
Yes.
much better than the tyranny of topical therapy.
Yep. And what do you think? And what do you find if it's the red face syndrome with the Dupixent? I mean,
Well,
I have had just a handful and it's hard. And
hardly none. I saw it more at the beginning, and I've also seen kids who've had it that, you sort of mess around with putting them on topical tacrolimus or something, and it just goes away. I
yeah,
saw somebody who had almost a psoriasiform, lesions on her face, and I, tried to treat her empirically for malassezia, cultured her for dermatophyte. All that was negative, and after 6 months, it was just gone and never came back.
yeah, yeah. And definitely, I do think, we can start to think and talk about remission with these medicines because you do see that where, and again, it's the art and the science, and it's not, these are all FDA off-label things that we talk about when we're talking about tapering treatment. How do you do that? And I think it's really individualized, right? I mean, I didn't have a cookbook recipe for it. It just, we're learning together. Our patients are teaching us. And again, some of this stuff in PD derm, thank God we have so many more trials and data that we can look at and long-term data that we didn't have before. But some of it you are practicing the art of medicine.
But I can't say enough about our partners in industry. There's a lot of disparaging comments about, big pharma and things like that. But, in pediatric dermatology, our patients are largely therapeutic orphans. And, only recently has there been a mandate to study kids like that. But NIH isn't funding these kind of studies. We need our pharmaceutical company partners, and they've made such huge inroads. And many companies, and I'm going to give a shout out to Regeneron and Sanofi, that they are great partners, and you bring issues to them that you want to know more about that are not primary endpoints of that study, and they are there to spend money trying to get an answer to that. And one of them is about long-term remissions, by getting off of their drug. So that is an actively ongoing study. But, short of that, because we don't have we don't have good numbers about that. But I have seen patients with long-term remission, kids that I know stopped it that I haven't seen back again. So, at least that's what I think.
Mhm.
And I've also seen kids who have remission for a couple years and then it comes back, or kids that just have remission for a couple months, and you can't really predict who that's going to be.
Yeah, there's no set pattern I found
Yeah.
for that. How about cyclosporin? Do you use cyclosporin? So the overlap kids, they're, in the methotrexate bucket potentially. And I agree, methotrexate is an oldie but goodie. You taught me how to use it. And, there's just such long-term safety data in kids with juvenile rheumatoid arthritis and other autoinflammatory conditions. And it's just, I actually feel quite comfortable using it.
I
Because
wish it could be used as an active comparator. So for the learners out there, you can't design a clinical trial and require an active comparator that's not labeled for that indication. So we're never going to have it that way, unfortunately.
Yep, yep, that's true. How about cyclosporin? Do you use much of that?
I haven't used that in, I don't know, a decade or more. I used to use a lot of it. I've used them all. I've used azathioprine and Cellcept and cyclosporin and a lot of IVIG too.
Mhm.
None of them can compete with, really either methotrexate or dupilumab in terms of, just cost and efficacy and.
Right. So how about the JAK inhibitors? What do you think about that can of worms?
I have put a couple of kids on JAK inhibitors for who have horrendous allergic contact dermatitis to everything under the sun, who didn't do well on, because they failed methotrexate and they failed dupilumab, and then I finally, capitulated to the JAK inhibitor. One pearl about that is that I had one kid who was on dupilumab because he was atopic and had bad allergic contact dermatitis. And I told his mom, and him, he was a teenager, that we could just cross them over, maybe, add the JAK inhibitor and, sort of see what happens. Well, we couldn't get his insurance to pay for that. So, and that's another unfortunate thing, because I think JAK inhibitors are incredibly effective, don't you? I mean, they really do work, but what are you going to do long term? And that goes for alopecia areata too, you're going to keep them on that forever?
Yep, and vitiligo. It's hard. It's hard because, again, it's a newer drug. So there's still more story to be written.
We
Just
got
like
1 year safety data in adolescents, and that's pretty
yeah.
much it.
Yep, that's pretty much it. But then you go back and you look at the drugs, like basically atopic derm is now what psoriasis was 15 years ago, right? That's where we're at with it. And it's great. The biologics have really advanced for pediatric psoriasis too. And I feel like more people are comfortable with those, and the indications just keep getting lower and lower for those drugs as well.
Yeah, it has been great. We could talk about the new kids on the block for atopic dermatitis, Trelo, Kinumab, and
Yeah.
Lebrikizumab. Lebrikizumab's not FDA approved yet. But
Yeah.
Trelo is now on down to adolescents, I think 12. I have to look that back up. I don't know if we got lower than 12. One of the big distinguishing features between Dupixent and Trelo is their targets, right? So Dupixent is a IL-4 receptor, type 1 receptor antagonist, and Trelo binds IL-13. And in doing so, let me just get this straight. It does not bind the decoy receptor. I think Lebri binds the decoy receptor. Oh, I have to go look this up again. But, that's another area of limited understanding, is what the heck that decoy receptor does. And, is it important to bind it or not? My gut feeling is that you don't want to bind it, because if you start going down the rabbit hole of reading about the IL-13 type 2 decoy receptor, you'll get a lot of information about what it does. And it's not just that it sort of sops up extra IL-13. It has its own very potent activities. But I think only time will tell, because the difference between Trelo and Dupi. And I don't have much experience at all. I'm going to tell you one thing about access, but I don't have much experience because I didn't have problems with access to Dupixent. But recently in the state of Missouri, they required a step edit that you had to use Trelo before you use Dupi. And, that I actually testified at the subcommittee to try to get that reversed, because part of using all of these medications, there's a learning curve, and it's just as much of a learning curve as learning a surgical procedure. So you can't just go and use something different, if you don't know how to use it and you're not familiar with it. And I wish that payers would understand that.
Yeah, and it's so important for us to be advocating as dermatologists for our patients, locally, nationally. The Coalition of Skin Diseases does it. I mean, it's important for us, the AAD. So we all need to be speaking up, because, while they're a collective voice for us, people lawmakers want to hear from their constituents, and it's the individuals reaching out and continuing to, again, having relationships with an allergist, but also having relationships with your lawmakers is important, and being in their ear and becoming a trusted advocate for them. Because sometimes, again, we don't know what we don't know. And I think lawmakers sometimes appreciate having somebody that they can go to with these kind of questions, and building that trust relationship with them can really help our patients in so many ways.
Yeah, it
Um,
was interesting. The thing I think that resonated to the committee the most, because I was giving them a lot of different arguments for why having a step edit like that didn't make sense, particularly for children. But the one that resonated with them the most is the thing about experience. That was interesting. But
yeah.
speaking of that and Trello, I don't have any experience with that one yet. But I have talked to our colleagues who see adults who have much more experience, maybe participated in the clinical trials, have seen patients that for reasons that they don't really understand, even if they didn't respond well to Dupy, they responded to Trello. So, that didn't make that much sense to me, but hearing that people had that clinical experience makes me much more willing to transition from Dupy to Trello rather than trying something like Dupy to, I don't know, use ustekinumab or something for somebody who might have an overlap phenotype.
Yeah, that makes sense. That makes sense. So, do you have a first line that you go to for psoriasis? I know we're talking a lot about atopic derm, and that's
Yeah. Um,
that's a good one to
I,
talk about because it's so common. But how
yeah.
do you have an algorithm a little bit for psoriasis in the available dose?
I do use methotrexate first for psoriasis because I do think it works well. And we did a study that looked at efficacy in our patient population. We were looking at methotrexate polyglutamate level, which, by the way, now I believe it's LabCorp. I used to send that to Exogen, which only gave you the polyglutamate 3 moiety, and LabCorp has a test that gives you all across the board. So that
Ah,
you know if you're glutamating the longer rather than the shorter, that methotrexate is going to be more likely to be effective for you. So anyway, I use a lot of methotrexate in first line because the kids did better with psoriasis on methotrexate than they did with eczema. But, there's a lot of kids that don't do well with methotrexate also. And you have to go with what they get access to. And a lot of payers are, requiring adalimumab, Humira.
yeah,
I like ustekinumab much better strictly, well, first of all, because of the mechanism of action, but also it's a once every 3 month injection once you get to
right.
that point, and that makes a big difference for people. But you do have to worry about, any lupus, predisposition, but it does also, for the kids who have, that Crohn's phenotype or have Crohn's too, that
Right.
one's a good one.
Yep, it's a great one. I agree. It's my
Whereas
favorite.
the 17s are, you can't do that with that population.
Right, right. Yep, that's a good point. A good point. All right. How about any other pearls as far as dosing, intervals, increasing, decreasing? Again, that's probably four questions in one.
Yeah, I don't know, and we're all flying by the seat of our pants with what to do with the kids who are doing well. And so my approach is that I don't change their dose unless they're, clear, almost clear, although I'm really starting to change to clear, rather than almost clear. And the first thing that I do is I just have them, well, you can do two things. Like if they're on a 300 milligram dose, you can put them on a 200, or you can just increase the interval between their injections. And another really good clinical, I think, sign is you ask them, you make them be aware of whether or not they start itching pre-injection. I mean, you don't want to lead them on, but
Yes.
I think it's a good thing to do. So if you're increasing the space between their injections, so you can go, from every 2 to every 3. I usually you'll do that for a couple, 3 months, and then every 3 to every 4, and then every 4 to every 5, and then at 6, I stop. And the reason that I stop is mostly because of a poll, from people, what are they willing to stop, and also because of that concern about anti-drug antibodies. So we don't have much data on that, but we do have a little, and the incidence of anti-drug antibodies definitely increases the longer that you space out the dosing.
Okay. That's good to know. Good to know. Because yeah, so the anti-TNF certainly an issue, but yeah, again, we're learning with time about these as well, and the likelihood is yes, there probably will be some level, but it's interesting.
Yeah, I remember discussing anti-drug antibodies with my pediatric GI colleagues, 10 years ago, and they weren't checking the anti-drug antibodies. Like for us dermatologists, we were treating the patients on infliximab with a little bit of low-dose methotrexate just from the get-go, and they
Mm.
weren't paying any attention to it until it became commercially available. So then it was infliximab, adalimumab, and now we have commercially available ustekinumab antibodies. So I just think people don't want to think about that so much. And it's certainly not the majority that have
Right.
that, but if it's you, it matters.
Yeah, and it's really more, I mean, clinically, you base it on your clinical. If they're not improving anymore, or they're getting worse, they're flaring, it's worth checking. I mean, it's worth thinking about and checking. But if they're going along great, then of course you're not going to have to worry about that.
Right.
Yeah, so all right. How about immunizations for kids? That can be a tricky issue with being on a biologic.
And I have to apologize. Like we did a guidance document for designing new clinical trials for children with severe inflammatory skin disease many years ago, to try to incentivize, better trials that you could compare apples to apples and oranges to oranges. And that was a labor of love for several years. And when I look back on it now, we didn't even mention immunizations. They weren't even included in any of the clinical trials. And then here we are, great drug, FDA approved down to 6 months of age, and we're getting inundated with what do you do about this? And
Mhm.
so, from my perspective, you can take one of two pathways. One is you can go with the standard CYA pathway, which is what is in the label. So the label says, no live vaccines, and killed vaccines. You have to wait, I think, 6 weeks after the vaccine to initiate treatment, or you have to be off the treatment no, I think maybe to be off the treatment for 6 weeks, 2 weeks before and 6 weeks after,
Yep.
because it takes about 6 weeks to clear the biologic from your system. So that's kind of the standard recommendations that people use. But, I always had some suspicion about whether or not we really needed to go that route, knowing how
Right.
important immunizations are, knowing that children who have bad atopy are more susceptible to all kinds of infections. So you want to make sure that they're immunized. And also the mechanism of action of anti-type 2 drugs, because in theory that should actually enhance your response to the vaccine, and it should enhance your immunity a little bit better. So it doesn't seem to me that it made sense to change their immunization schedule. So what we did was, when we were doing the clinical trials, we had a few patients who it had a protocol violation, because in the trials you had to do the party line, no live viruses, and
Mhm.
you had to withhold the killed viruses. But we had patients who did it anyway because they didn't tell their pediatrician that they were in a trial, and we didn't give them any prospective good guidance about that. So we went back and retrospectively looked at all the kids across the clinical trials, which again, another great kudos to Regeneron for
Mhm.
spending the effort to do that. And it's not a wonderful trial; it's a retrospective study, but we didn't find any problems with them. We didn't do titers. Of course, titers are not the be all end all measure of vaccine efficacy. But we worked on another project like that we're just about to publish, just in our own big institution, about kids who got exposed to live virus vaccines on Dupixent. And we really didn't find anything either. And there are other efforts underway to try to study that, although it's a very difficult trial to do. So I don't think it's going to happen in any big way.
Yeah, yeah, I agree. I agree. Those are the interesting, again, art of medicine kind of thing. So how about any other logic that you use in biologics? That would be some clinical pearls, and then we'll kind of summarize what we kind of reviewed.
I think the big one, and you might have more to say than me about it, but just having targeted biologic treatment it's so wonderful for the children who have rare disorders. So at the SPD meeting, there was a case report of a kid who had Netherton syndrome. And I know because our friend Amy Paller did a clinical trial that they were using ustekinumab for inflammatory ichthyoses, and it didn't really work too well. In fact, one of my patients with it wasn't Netherton's, it was Harlequin. So one of my patients with Harlequin participated in that study, and ustekinumab didn't do much for that patient at all. But at the SPD, they presented a Harlequin kid who even started growing their hair back. Amazing. So,
Yeah.
knowing with the vast array of genodermatoses and being able to apply, sort of what we know and get orphan indication access to these medicines is it's so promising.
It's
Have you
so
had any
promising.
experience with targeted biologics for rare
For
diseases?
genoderms, no, I really haven't, but I know, like, and again, I guess, hidradenitis suppurativa isn't that rare either. It's seems rare because people don't ever want to talk about it. And I feel like that's the case for so many people with skin disease, right? They kind of hide in the shadows. And now that newer medicines are coming out, they're coming out from the shadows. So I think, again, a lot of the things we thought were rare might be a lot more common than we realized, but kids didn't talk about it.
Yes, this problem of early adolescence with bad hidradenitis. I mean, I'm seeing that more than I used to, maybe
Mhm.
because there's some, more buzz about it. But I haven't really had that much success with adalimumab. For those kids, if I have to go beyond standard treatment, with just antibiotic and cleansing, and then directed tunnel surgical treatment, which I don't
Right.
do, but I send to them.
Yes.
Then I'll go to very, very low dose isotretinoin.
Yep. And I think that can work. I've had a little bit of success with biologic, but again, I think, there's also interest in that condition as well. So I'm excited to see what comes out for that population that's kind of been an orphan as well as some of these others. So yeah, it's really an exciting time. It's an exciting time to be a pediatric dermatologist. It's an exciting time to be taking care of kids with skin disease because again, we're not just telling them to soak and smear and put on wet wraps anymore, right? And again, what a terrible thing that is really when if you have to do it to your kid every day and every night, like it's horrible. It's miserable. It's not even, and then of course non-compliance is high, and it's not because these parents are bad parents. It's because what we're asking them to do is nearly impossible.
Yeah, really.
So it's really just such a gift to have these medicines available for these kids. And
I do
yeah,
want to say, but for anybody in industry or any researchers, that hidradenitis is our next big unmet need, and particularly in, adolescents and early adolescents. And then the other big unmet need is lichen planus, lichenoid
yeah,
conditions. We don't understand that.
no.
And also the immunology of allergic contact dermatitis.
Oh yeah. Oh yeah, baby. And now that I'm an allergic contact dermatitis survivor myself, it's high on the list. It's high on the list. All right. So just wrapping up, let me see, check the chat just real quick, just to make sure there's no questions. No questions right now. But so many of our learners do asynchronous learning, which is a great way to learn nowadays as well. So, if anybody does have any questions, you guys can always reach out through the PD Derm email. And if there are questions that I can't answer, I can get Dr. Siegfried, who just has a way of knowing everything about everything, in my opinion. Whenever I am stuck, she's the first person I'm on the phone with, the first person I'm texting with. And it is just such a gift. What Dupixent is or dupilumab is to atopic dermatitis patients, Elaine Siegfried is to me. She's been such a gift. But anyway, so
When I'm feeling low, I just call Alana and she makes me feel better.
it's what I do. It's
Yeah.
what I do. But yeah, so all right, wrapping up. Let's highlight the highlights. You want to help me highlight the highlights? So basically, labs. What do you get? Let's go over it again.
My baseline's a CBC, CMP, vitamin D, like usually a respiratory allergen panel. And I think about a histone and an ANA for, kids that I'm really suspecting of immunologic dysfunction. And if they have a lot of infections, I'll start by just getting them vaccine titers in pneumococcal, Hib, diphtheria. H flu, diphtheria, and tetanus. Yeah, and
Okay.
then you can just see, but most of the time it's pneumococcals that is their selective antibody.
Yep, yep. Okay, so baseline labs, we talked about that. We talked about kind of our phenotypes, the furuncles and pustular kids definitely think about being a double dipper no matter what they're on and their creams and their treat, all of those things. Atopics, certainly the atopic diathesis, dupilumab, dupilumab, dupilumab.
And we got to pay attention as dermatologists to all of their atopic morbidities and their growth curve.
Yes.
Get a weight, get a height, and pay attention to it.
Yeah, and just plug it into the EMR and it'll put it on a growth curve. You don't got to plot it out anymore like we used to back in the old days when we had floppy disks to take pictures of patients. And you had to plot
A
out the
long
growth
way.
curve. Yeah, there's no reason not to do it. All right. And then as far as other oldies but goodies, methotrexate, still an oldie but goodie, long-term data. You do need to screen labs, but I do find that there are a subset of kids that prefer to be on methotrexate over, you know, being on dupilumab. They just think it works better for them if they've been on both. I've had some that asked me to go back.
Me too. Not many,
Yeah,
not many.
not many, but there's a handful.
Yeah.
So, and then as far as failures, we're learning about failures. Could that be anti-drug antibodies? Could it be we're not hitting the right target? It's not the right phenotype. And Peso agrees. It's the wrong the wrong drug for the wrong disease, and we're going to learn more about that over time. Immunizations, again, sticking to the party line, but probably we might find that we don't have to as things go forward. And then certainly the art of medicine and tapering. And again, it's just listening to your patient, which, that is a good skill that we should never lose.
Listening to them and looking at them.
Oh yeah, and touching them. Oh
Yeah.
my goodness, putting your hands on a patient. Not only does it help you with, diagnosis, and it helps the patient feel better too because they're connected to you and they know that you see them as the person in front of them, not the disease.
And I have to give a final plug for Dr. Bree because I have referred many patients to, oh, now you got to tell me
Made a
what.
masterpiece.
Made a masterpiece. Yeah. And they really, not all of them, but many of them are very impacted by their disease, and Made a Masterpiece is such an incredible organization and resource for them. And I've had a lot of patients that, really could benefit from that kind of support.
Thank you. Yeah, and since we've moved from being more an in-person facility in Houston and we're online, we're growing our resources and doing a lot of great things and really finding that we're reaching more kids when you look at the analysis and the data behind the scenes. So these kiddos, they struggle. They struggle. We need continued good treatment. So pharma, keep on going, keep on going. We're so thankful for you
And
for
we need people like Dr. Bree who understand and recognize these things that so many others have ignored, which is about their how the personal impact of their disease.
Yeah, the whole person, holistic care. It might sound fluffy, but it's real. There's nothing fluffy about it. It's, just because we don't have a marker necessarily, you can tell when these kids are suffering, and you just give them that little opportunity and open the door to let them talk about it, because many people don't. It's really special. It's really special. And then anybody that has an interest in PD Derm, we would love to have you come to an SPD meeting, reach out to us, learn about the field, because it is amazing. And, what I found exciting is you can develop a lot of things. There's so, you can be a really big fish in a small pond pretty easily. You can become an expert on a niche disease like AEC, right? Like, and again, it is, there's so much opportunity within a very special community of docs. And I think the mentoring through the Society of Peds Derm, there's nothing better.
And
There's
the
nothing
key
better.
is within a very special community of healthcare providers.
Yep. Yep. So, all right, Dr. Siegfried, thank you, thank you, thank
Okay.
you. I appreciate your brilliance. And again, if anybody has any questions when they're looking at this later on, please reach out. We'd be happy to help you because we want more and more kids to love the skin they're in. Good night.
Hey.